first question that you have is, a 22-year-old young male, college student, left knee injury while playing hockey. Hardly any piece of information till now. After 2 months, there was an anterior laxity in full extension, quite a bit of an information, but it was normal at 90-degree flexion. What is the most likely injured part? See guys, when you move further to understand this topic, let me make one thing crystal clear to you, that here we are actually talking about anterior cruciate ligament, or in other words ACL. Now when we talk about anterior cruciate ligament or ACL, I want you people to understand what is the job of ACL first. That's the first thing. See, anterior cruciate ligament, the purpose is to ensure that there is no anterior translation of tibia with respect to femur. You have to understand this. Let us say if this is the femur bone, this is the tibia bone. The job of ACL is to ensure that there is no anterior translation of tibia with respect to femur. But this job is performed at different positions by different bundles of ACL. So first of all, you should know that what ACL does, it prevents, it prevents excess anterior translation. It prevents excess anterior translation of tibia over femur. This is the job of ACL that I want all of you to know. Now the second thing that you should know is that this ACL further contains, this ACL further contains two bundles. There are two bundles of ACL. One is the anteromedial bundle. Understand my point? One is the anteromedial bundle. The other one is the posterolateral bundle. Alright, so we have anteromedial bundle, we have posterolateral bundle. Both the bundles are going to perform the same job as that of ACL, but they're going to perform these jobs at different positions. Now when I say different positions, what does that mean? That when your knee is in 90-degree flexion, then in this particular position, this bundle, anteromedial bundle, will be tight. Now when I say it will be tight, that means it is going to perform the job. Well, at the same time, the posterolateral bundle is going to be relaxed. You understood my point? So anteromedial bundle will be the chief working tight bundle, while posterolateral bundle will be relaxed. But when we talk about when knee is in complete extension, then this bundle is not going to perform the job. Anteromedial bundle will be relaxed, while posterolateral bundle will be comparatively taut. So it is a PL bundle which will be performing this activity. I hope that makes some sense to you. Now if you see the question again, there is anterior laxity. See, there is anterior laxity. The anterior movement of tibia is there. But there is anterior laxity in which position? Full extension. Whose job was to prevent that anterior laxity? You have to think it like this. Tell me, whose job was to prevent that anterior laxity in full extension? In full extension, whose job was to prevent that anterior laxity? This bundle, because it is taut in this position. So it was a job of posterolateral bundle, but since there is anterior laxity, that means PL bundle is not working. That means PL bundle is torn. Now we have to see whether AM is torn or not. So now if you see, it was normal at 90-degree flexion. Now which bundle has the job of preventing anterior laxity in 90-degree flexion? This is anteromedial bundle, so it is tight. So that means AM is intact. PL is torn. So answer is to be PCL, no. Middle meniscus, no. Anteromedial, posterolateral. Anteromedial, no. Posterolateral is the answer. Is this first question clear to all of you? This is about the two very important bundles of ACL. Now moving over to the second question. All of the following can be the result of the carpal tunnel syndrome except. See guys, you have to be very careful with this question. The only thing that I want all of you to remember in this question is that when median nerve, making a very weird kind of a drawing, pardon me for that, but when median nerve enters at the level of wrist, alright, when median nerve enters at the level of wrist, it divides itself into two aspects. One is the superficial division. One is the deep division or deep branch, whatever you want to call it. Now, you have to understand one thing very clearly, that this superficial division, or in other words, the superficial branch, it is superficial to what? You have to understand the terminology. Why superficial? Why deep? Superficial to what? Deep to what? Carpal tunnel. You understand my point? Superficial to what? Deep to what? Carpal tunnel. So it is actually the flexor retinaculum. It is actually the carpal tunnel. When we say superficial and deep, it is superficial and deep to that. Now this superficial branch is called as Palmar cutaneous branch. All right. It is called as Palmar cutaneous branch of median nerve. Now you might be wondering why it is called as Palmar cutaneous branch, because it is just a cutaneous branch which has got no motor component at all. It is just going to supply the skin over the thenar eminence, and that's all. So this will be sensory 2. I repeat, this will be sensory 2, just sensory 2, skin over thenar eminence. This will be sensory to just the skin over thenar eminence, and that's all. Its job is done, it is finished, it is over. That nothing else can be done by the Palmar cutaneous branch. Now while we talk about the deep division, alright, when we talk about the deep division, we also call it the carpal tunnel branch. Why? Because it is actually entering into the hand, it is actually entering into the palm via carpal tunnel. That is why probably we call it the carpal tunnel branch. It's a big branch, and now what we do is we divide it into two parts. We make two divisions out of it. One is called as the lateral division, one is called as the medial division. We make two divisions out of it, lateral division and the medial division. Now very interesting point is that lateral division is mainly motor. Now when I say motor, what does that mean? That means that it supplies Abductor pollicis brevis. I hope you remember the name of this muscle. It supplies opponens pollicis. It supplies flexor pollicis brevis. It supplies flexor pollicis brevis. And even in flexor pollicis brevis, mind you, particularly the superficial head. So in motor division, opponens pollicis, flexor pollicis brevis, superficial head, and abductor pollicis brevis. I hope you guys are aware of the fact that median nerve also has to supply lumbricals, and particularly the two lumbricals, particularly the four lumbricals. In the four lumbricals, I hope you remember that first two are supplied by median nerve. So it will also supply the first lumbrical. It is a very interesting point. Now I said it is mainly motor. Lateral division is mainly motor, but you know what, that doesn't mean that it is only motor. There is some sensory component attached to it, and that sensory component is that it has to supply what? Over thumb, over index finger. It has to supply thumb, index finger precisely which part? The lateral half. Now when we talk about the medial division, it is mainly sensory. As I said, it is primarily sensory. And it is sensory to what? What is left behind? Index finger, medial half, entire middle finger, and the ring finger, lateral half. It is sensory to that. And mind you, it is not only sensory to this area. I mean, it has got some motor component, and that motor component is that lumbrical which is left behind. That is the second lumbrical. Right? That is the second lumbrical. You understood my point? So lumbricals in a way are very unique. Like first lumbrical is supplied by the lateral division of the deep branch of the median nerve, while second lumbrical is supplied by the medial division of the deep branch of the median nerve. So you have to be very careful about that. Let's take a look. Now when you see this question, all of the following can be the results of carpal tunnel syndrome except, see, carpal tunnel syndrome, we all know what carpal tunnel syndrome is. It is compression of the deep branch of the median nerve inside the carpal tunnel. Malum hai na? Now paralysis of opponens pollicis, that will be a part since it is supplied by that nerve. Pollicis brevis, flexor pollicis brevis paralysis, yes. Although one head is supplied by that nerve, but still yes. Paralysis of abductor pollicis brevis. Yes, it is again a muscle supplied by the same lateral division of the deep branch. Paralysis of oblique head of adductor pollicis. Absolutely wrong. Why? Because this is supplied by something which is called as ulnar nerve. What has that, something to do with the compression of the median nerve? So answer is C. Does that make sense again? Chalo. Let's talk about question number 3. Question number 3 says, during reimplantation of an amputated limb, which of the following is done first? Interesting question. Guys, you have to understand one very basic thing, that whenever you have a chopped off limb or a chopped off digit, and when we try to reimplant that digit, we follow a particular sequence. And what I can do for you is that I can give you the complete sequence in the form of a mnemonic so that it is easy for you to understand. B, B, E, fan, F-A-N of V-S. So the mnemonic goes like this: B, E, fan of V-S. B, E, fan of V-S. Now when I say V-S, Virender Sehwag or whatever you want to call it. Now what is B? The first thing to be fixed is always bone. After bone, the second thing always to be fixed is extensor tendon. The third thing always to be fixed with is flexor tendon. The next thing always to be fixed is artery. The next thing which is always to be fixed is nerve. The next thing which is always to be fixed is vein. And the last thing which is always to be fixed is skin. So this is the sequence that I want you to remember: B, fan of VS. So bone is always the first structure to be fixed. So answer is C, simple fixation of bone. Next question. Question number 4. Elderly female, okay, treatment for osteoporosis, all right, with alendronate, with a bisphosphonate, with alendronate for 7 years. That's a pretty long time. She now presents with complaints of hip pain. The next investigation for her would be. So guys, you have to understand one thing very clearly, that when we are talking about this question, we are actually talking about this very fantastic drug that is called as bisphosphonates, which I'm sure you all guys are aware of this fact that bisphosphonates are the drug of choice. Alright, I'm sure you guys are very practically aware about this fact that bisphosphonates are the drug of choice for osteoporosis. Now the problem with bisphosphonates is that it has to be given intermittently. You understand my point? I mean, you cannot give bisphosphonate in a continuous dosage or a continuous duration. You have to understand that. Because whenever it happens, there are certain problems. What are those problems? Don't worry, I will explain that to you. See guys, you have to understand what osteoporosis is all about. First, you have to think of it. There is a cell called osteoblast, bone formation. There is a cell called osteoclast, bone resorption. Blast makes bone, clast eats bone. In osteoporosis, there is excess osteoclastic resorption. So the purpose of bisphosphonate is to stop osteoclast from resorbing the bone. But at the same time, I want you people to understand that osteoclast, apart from resorption, it also does something which is called as R for remodeling. You have to be very careful about this fact. Osteoclast is responsible for R for resorption of the bone, R for remodeling. Where resorption in excess is bad, but remodeling is a very good process. Now the problem is that when we give bisphosphonate, whether in excess dose or duration, that stops osteoclastic activity. That stops osteoclastic resorption. We are happy, but oh my God, there is a collateral damage. The collateral damage is that of course it stops osteoclastic resorption. It also stops the osteoclastic remodeling. And bone is a very dynamic tissue. Modeling, remodeling, formation, resorption. You have stopped the dynamic part. And when you have stopped the dynamic part, the bone will land up into what? The bone will land up into a dynamic bone syndrome. Bone will land up into a dynamic bone syndrome. The dynamicity will be lost. The bone will land up into a dynamic bone syndrome. There is no remodeling. And how do you get to know about that clinically? The lady who has been taking bisphosphonates in excess dose or duration will now start complaining of a vague hip pain. She will start complaining of a very vague kind of a hip pain. Apart from that, she will have certain fractures which will be seen on an X-ray. I will explain that to you. Let's just quickly write it down. So excess dose or duration of bisphosphonates consumption will lead to adynamic bone syndrome, in which clinically there will be a vague hip pain, but as far as X-ray is concerned, it will land up into an atypical subtrochanteric fracture of the femur. What is so atypical about it? I will tell you what is so atypical about it. Normally in elderly age group, whenever you see a fracture, you see more than two fragments, you see comminution. So there is no comminution. That is the first thing. Second thing is that these fractures will be transverse in line. Third thing is that they will have a lateral cortical thickening. The fourth thing is that these fractures do have a medial spike. So they are almost like this. Alright, so these fractures will be almost like this. They will have a lateral cortical thickening. They have a medial spike. And there are transverse lines without any comminution. Does that make sense to you? So the next investigation, or the best investigation for her, would be X-ray. Answer to question number 4, I guess, is clear to all of you. Now let's talk about question. You can see the fracture again. All right, you can very clearly see the lateral cortical thickening here. You can see the transverse fracture line. You can see all these things. Okay. Now, next question, let's talk about question number 5. Now, when we talk about question number 5, I'm not going to read out question number 5 for you. I'm going to just straight away, talk about a very important topic here that is called as Paget's disease of bone. I will be, straight away discussing the topic here with you. See, when we talk about Paget's disease of bone, before I start the discussion, I'm sure you guys are intelligent enough to understand that osteoblast makes bone. Osteoclast eats bone. Very simple. Okay. Now, what I want you to understand is that there is something called as a high turnover bone disease. You have to understand. Now, when I say high turnover bone disease, what does that mean? That there is too much of formation. There is too much of resorption. You understand my point? Paget's disease is a high turnover bone disease in which there is too much of formation, too much of resorption. Patients are usually asymptomatic. They're diagnosed incidentally. What does that mean? A gentleman, 40-50 in age, is not having any problem of the bone at all. It's just that he gets his general body checkup done and he gets his liver function test done and his all enzymes, SGOT, SGPT, GGT, everything is normal. It's just that his alkaline phosphatase is 8 to 10 times the normal. He goes other examination for liver also and everything is normal. It's just that an asymptomatic male with a 8 to 10 times elevated level of ALP is there. Is Paget's. This is Paget's. Too much of formation, too much of resorption. So let's write it down. This is an excess bone turnover disease. There is a excess bone formation with excess bone resorption. The most common bone involved is pelvis. Classically asymptomatic patients incidental diagnosis, if at all there is a symptom, then first symptom is backache. Yes, cranial nerve deficits are seen. Sensory neural hearing loss is seen. High output cardiac failure is seen. All these things are seen. Alkaline phosphatase levels are usually 8 to 10 times the normal. When we talk about X-rays, you see certain very important signs. Blade of grass sign, which is also called as the flame sign. You see cotton wool skull. You see picture frame spine. You see osteoporosis. There are many things, many things that you see. You see osteoporosis circumscripta. And in fact, there are other signs also. In fact, I would want you to know that Paget's disease is considered to be the most common pre-malignant lesion for development of secondary osteosarcoma. Although incidence is very less, but still it is there. Drug of choice, undoubtedly, bisphosphonates. So these are some important salient features about Paget's. Let's take the question now. So question is simple, that all are features of Paget's disease except it's a defect in osteoclast. Yes, there is too much of osteoclastic resorption along with bone formation. Calcitonin is the drug of choice. No, calcitonin is not the drug of choice. What is the drug of choice? It is bisphosphonate. Next, can cause deafness. Yes, it can cause sensory neural hearing loss because of the cranial deficit. Can cause osteosarcoma. I've already told you, mere bhai. I've already told you the most common pre-malignant lesion for development of secondary osteosarcoma. So answer has to be Bombay. Now question number 6. Which of the following is not a feature of Kodi's fracture? Don't worry, I'll make it simple for you. It is very simple. When we talk about displacements in Kodi's fracture, okay, I've written here. When we talk about displacements in Kodi's fracture, we have to just remember this mnemonic. The mnemonic is called as DILS. The mnemonic is called as DILS. Now, when I say DILS, what does that mean? That means dorsal tilt. That means impaction. That means lateral shift. That means supination. Alright, so this is dorsal, impaction, lateral, supination. Alright, dorsal, impaction, lateral, supination. Now, when you see the options, you have dorsal, yes, you have radial displacement. See, radial means lateral. You have to understand, radial means lateral. You have supination, yes, but you have volar tilt. No, you don't have a volar tilt, you have a dorsal tilt. Alright, so answer will be A. Now question number 7. Identify the cast. What do you think about this cast? This is a PTB cast. This is the patella, this is the patellar tendon, and this is your tibia. So this is a complete patellar tendon bearing cast. So full form is patellar tendon bearing cast. It was a classical concept of a functional cast brace actually. I mean a kind of a cast in which the person can be ambulatory, can move up and about. And the classical example was always fracture of shaft of tibia. Okay, the classical example is fracture of the shaft of the tibia. Now question number 8. Identify the spine shown here. So you have one vertebral body, another vertebral body, then another vertebral body. You have 3 different vertebral bodies. I'm sure you guys can see them very clearly here. You can see the height of one, you can see the height of another, and then you can see this one. So do you see this concave superior end plate, concave inferior end plate? I'm sure you guys can see all of these. So beta, what I'm talking about here is what is called as a fish mouth spine. Somebody call it codfish spine, somebody call it a biconcave vertebra, different people give it different names. But yes, this is a fish mouth spine. Now it is seen in two conditions. One is the osteomalacia. The other condition is osteoporosis. It is very interesting that we should remember that it is seen in both the condition, osteomalacia as well as osteoporosis. But one thing is classical, that it is more seen in osteomalacia as compared to osteoporosis. It is more classical of malacia as compared to porosis. Please do remember this. Now, the second thing that you should remember here is rugger jersey spine. Now, when we talk about rugger jersey spine, you have to understand rugger jersey spine, just like rugby player. So, in rugger jersey spine, I'll tell you. Ideally I should use a white color, but I can't here. So, in rugger jersey spine, the superior end plate will be thick, dense, white, sclerotic. The inferior end plate will be thick, white, dense, sclerotic, while the anterior posterior end plate will remain normal. Okay, this is seen in again two conditions. One is the renal osteodystrophy. The other will be called as the osteopetrosis. So it is seen in both the conditions, but yes, renal osteodystrophy is more commonly involved as compared to osteoporosis. Then we have something which is called as, I hope you remember, I had already mentioned in pages also, picture frame spine. So in picture frame spine, superior end plate will be thick, inferior end plate will be thick, anterior end plate will be thick, posterior end plate will be thick. All four end plates will be thick. And P for picture frame, P for Paget's disease, simple. Then if you have a vertebral body like this, and if you have these connecting, syndesmophytes, which are called as the marginal syndesmophytes, then we call this kind of a spine, we call it bamboo spine. And guys, you know what, it is so classical of a condition called as ankylosing spondylitis. Okay, so not only we have discussed this question, but we have discussed different types of spine, although this is fish mouth spine, but I wanted to see other types of spine. Now question number 9. The test shown below is used to diagnose. See, this test is a classical Finkelstein test. It is a classical Finkelstein's test. And in this Finkelstein's test, you check a condition called as de Quervain's tenosynovitis. You check something that is called as de Quervain's tenosynovitis. Now, what is de Quervain's tenosynovitis? This is inflammation of common synovial sheath. Of APL and EPB. Alright, so this is inflammation of common tenosynovial sheath of APL and EPB, abductor pollicis longus and extensor pollicis brevis. Okay, so abductor pollicis longus and extensor pollicis brevis. There are two tendons here, abductor pollicis longus and extensor pollicis brevis. They have a common sheath. They form the anterior wall of anatomical snub box. They get inflamed, and because of that inflammation, you develop this disease, that is de Quervain's disease. Now what happens is, the moment you do a rapid ulnar deviation, see, this is the radial side, this is the ulnar side. Similarly, this is the ulnar side, this is the radial side. Can you see that? Okay, I marked it wrong. So this is the radial side, this is the ulnar side, again radial side, and this is the ulnar side. So the moment you do a rapid ulnar deviation, that provocates pain in the snub box and the anterior boundary. That is called Finkelstein test. Moving over to the last question, the most common carpal bone to get dislocated. See, when I say most common carpal bone to get fractured, Answer will be scaphoid. Most common carpal bone to get dislocated. Answer will be lunate. Alright. Largest carpal bone or most centrally located carpal bone will always be capitate. First two ossify will always be capitate. Last two ossify will always be pisiform. You should remember these basic one-liners. So answer is lunate. Alright, so far so good.